Vasculitis. Definition. Vasculitis is a group of clinical syndromes characterized by inflammation that predominantly involves the blood vessels of unknown etiology. Etiology, as scheme, classification, according to the size of the vessel involved, small vessels, Henochschen line purpura, Wegener's granulomatosis, and vasculitis of rheumatoid arthritis and systemic lupus erythematosus. Medium-sized vessels, polyarthritis nodosa, Kawasaki, and Church-Strauss syndrome. Large vessels, Takayasu disease, giant cell arthritis or temporal arthritis, aortitis associated with ankylosing spondylitis. Clinical picture: general, fever, fatigue, sweating, anorexia and loss of weight. Articular manifestations: arthralgia, arthritis, usually oligoarthropathy, myalgia. Extra-articular manifestations: same as general scheme, but each type of vasculitis can also cause specific manifestations depending on which vessels and which organs are affected. How to reach diagnosis of a case of vasculitis. Exclude other conditions which simulate vasculitis, such as atherosclerosis, vascular spasm, iatrogenic, ergots, or cocaine. Embolic conditions, infective endocarditis, myxoma. Conditions which increase thrombotic tendency, such as DIC, TTP, antiphospholipid syndrome. Exclude conditions which cause secondary vasculitis, such as malignancy, lymphoma, leukemia, drugs, NSAIDs, antibiotics, connective tissue diseases, rheumatoid arthritis and systemic lupus erythematosus, infections, such as rheumatic fever, infective endocarditis, Lyme's disease, cryoglobulinemia. Take notice of patient's age and gender, decide the extent of organ involvement, and try to fit the finding into specific vasculitic syndrome. Investigations: lab, CBC, ESR, CRP, urine analysis, Kift and Lift, rheumatoid factor, anti-nuclear antibody, antiphospholipid antibodies, anti-neutrophil cytoplasmic antibodies, or ANCA, ANCA, positive in Wegener granulomatosis and negative in polyarthritis nodosa. Vascular imaging, duplex and angiography. Other imaging studies: X-ray and CT scan for chest, echocardiography, abdominal ultrasound or CT. Biopsies may be needed for confirmation or exclusion. Skin, muscle, renal or temporal artery. Henochschen line purpura or anaphylactoid purpura or allergic purpura. It's explained in Rheumatology Audiobook. Wegener's granulomatosis, upper respiratory tract, sinusitis, epistaxis, lung, pulmonary nodule, kidney, glomerulonephritis, eye, scleritis, ear, otitis media. See ANCA, positive in 90% of the cases. Treatment is with high-dose steroids, methotrexate and cyclophosphamide. GIT involvement is uncommon. Church-Strauss syndrome, bronchial asthma and eosinophilia. Kawasaki disease, usually in children, red eye, red lips and mouth, red hands and feet, red skin, rash. Cervical lymphadenopathy. Vasculitis of coronary arteries, coronary aneurysm, myocardial infarction may occur. Treatment: aspirin and immunoglobulin are used. Cortisone is contraindicated because it increases the risk of coronary aneurysm. Takayasu disease, pulseless disease, affects the aorta and its branches, subclavian artery producing arm claudication and absent pulse. Giant cell or temporal arthritis, vasculitis of large vessels affecting cranial vessels, especially branches of temporal and ophthalmic arteries. Clinical picture: it usually affects the elderly, rare less than 50 years, with female to male ratio 4:1. General, malaise, anorexia, fever, night sweats, weight loss, and depression. Unilateral throbbing, headache, facial pain, scalp tenderness on brushing hair, visual disturbance up to sudden loss of vision, jaw claudication due to ischemia of the masseters. Polymyalgia rheumatica in 50% of cases, syndrome of proximal symmetrical muscle pain and stiffness, worse after rest. Investigations: elevated ESR, temporal artery biopsy, necrosis of media with inflammatory cells, such as lymphocytes and plasma cells. Biopsy may be negative even in true cases due to skipped lesions. Don't withhold treatment whilst waiting for biopsy. Treatment: prednisolone 60 mg per day, immediately to prevent visual loss from ischemic optic neuropathy. Once blindness has occurred, steroid therapies of no value other than preventing blindness in the other eye. Prognosis: most patients require more than 2 years of treatment. Relapse is common after stopping treatment, 50% if stopped after 2 years. Polyarthritis nodosa. Definition: systemic necrotizing vasculitis with aneurysm formation affecting medium-sized arteries. If only small vessels are affected, it's called microscopic polyangiitis. Etiology: autoimmune hepatitis B play a big role. Hepatitis B surface antigen is positive in 30% of the cases. Clinical picture: male to female ratio 2:1. Renal 60%, infarction rather than glomerulonephritis, hypertension and renal failure. neurological, stroke, mononeuropathy, mononeuritis multiplex, no pulmonary involvement in classical polyarthritis nodosa, cardiac, coronary heart disease, GIT, mesenteric occlusion, acute abdomen, genitourinary orchitis, musculoskeletal, arthralgia, myalgia. Hepatitis B is associated in 30% of cases. Notice that polyarthritis nodosa, so there are two no's, no C. anca, and no pulmonary manifestations. Investigations, biopsy, angiography shows multiple aneurysms, elevated ESR, mild eosinophilia. Hemoglobin hepatitis B surface antigen is positive in 30% of the cases. C. anca is negative, positive only in less than 10% of the cases. Treatment, cortisone and immunosuppressive. Osteoarthritis, definition, it's a degenerative arthritis characterized by breakdown of the cartilage with osteophytes formation resulting from wear and tear on the joints. It's the most common joint disease, and like rheumatoid arthritis, is not an inflammatory disease. Classification, primary and secondary. Primary, unknown etiology, genetic factors play a role, or secondary to congenital, hip dislocation, mechanical, occupational, sports injuries, endocrinal, acromegaly, myxedema, hyperparathyroidism, and diabetes, metabolic, hemochromatosis, others, and of any inflammatory or infectious disease. Risk factors, aging, more than 45 years, over time as the joint moves, cartilage deteriorates and smooth muscle becomes rough, people with family history of osteoarthritis. Sex, it's more common in females, obesity, loading stress on weight-bearing joints such as knee, overuse of joints. Then we have common joints involved are knees, the most common, some base, first carpal metacarpal joint, the second most common, hips, spine, cervical and lumbar, distal interphalangeal joints, Heberden nodules, proximal interphalangeal joints, Butcher's nodules, and finally the first metatarsobpharyngeal joint. These joints are affected in asymmetrical, oligoarticular or monoarticular pattern. Metacarpopharyngeal joints are uninvolved in primary osteoarthritis. Clinical picture. Again, it's the most common joint disease. Pain, it increases by exercise and decreases by rest. Stiffness may occur, crepitus on movement, minimal deformity and wasting of muscles around the joint. No systemic manifestations. Morning stiffness is not usually a prominent feature of osteoarthritis, but when present, it lasts no longer than quarter of an hour, unlike rheumatoid arthritis. Investigations, diagnosis is made on clinical and X-ray finding, normal laboratory finding, rheumatoid factor, antinuclear antibody are negative, ESR and CRP are normal, X-ray 70% of 70 years old, joint space narrowing, osteophytes, subchondrial sclerosis. Remember, if ESR is elevated, some other process is complicating the osteoarthritis, such as septic joint, because this doesn't mean that it's just only osteoarthritis. Treatment, physiotherapy, surgery, analgesics, paracetamol, short courses, intra-articular injection of steroids. Then we have polymyositis and dermatomyositis. Polymyositis, autoimmune inflammation of skeletal muscles. When associated with cutaneous lesions, it's called dermatomyositis. Clinical picture, we have the mnemonic MOHEM, M-O-H-E-M, M, myositis, mainly proximal muscles, symmetrical, involvement of esophagus, dysphagia, and involvement of respiratory muscle, respiratory failure. O, edema. H, heliotrope, discoloration of the eyelids. E, erythema, Guthrun's sign, symmetrical erythema over the extensor surfaces of the metacarpopharyngeal joints, elbows and knees. Diffuse, flat erythema over the upper part of the trunk and shoulder, the forehead. M, malignancy. This occurs particularly in males with age above 50 years. Investigations, abnormal EMG, muscle biopsy, elevated muscle enzymes, CK, SGOT, and LDH, myositis-specific antibody, anti-Jo1, 30%. Treatment, prednisone, 1 mg per kilo per day, then kept at 10 to 15 mg per day. Immunosuppressive, methotrexate, 5 to 20 mg per week, azathioprine, 50 to 150 mg per day, cyclophosphamide, IV gamma globulins, and anti-rituximab in severe cases. Infectious arthritis, classification, bacterial septic arthritis, non-gonococcal and gonococcal. Non-gonococcal, Staph aureus, streptococci, and gram-negative bacilli. Gonococcal, caused by Neisseria gonorrhea. Lyme disease, mycobacterial are immunocompromised. Fungal, sporotrichosis is the most common. Viral arthritis, risk factors, advanced age, drug abuse, diabetes, and suppressed immune system. Rheumatoid arthritis, artificial joints, recently joint surgery or intra-articular injection of cortisone. Bacterial septic arthritis, non-gonococcal septic arthritis. The clinical picture, flu-like symptoms, fahem, fever, anorexia, headache, and malaise. Acute joint pain, usually single joint, especially the knee. 80% of cases is monoarthritis. Signs of inflammation, hotness, redness, tenderness, swelling, limitation of movement. Investigations: blood, leukocytosis, elevated ESR, and blood culture. X-ray, articular erosions may occur. Synovial fluid examination, positive for culture and elevated neutrophils. The synovial fluid should be examined for crystals because gout and pseudogout can resemble septic arthritis clinically. Treatment: antibiotics, IV, according to culture and sensitivity test. Ox, clox, dicloxacillin, or vancomycin for staph for about 4 weeks. Analgesics and drainage of the infected joint daily. Gonococcal arthritis, most common in young, healthy adults, females more than males, caused by Neisseria gonorrhea. Clinical features: migratory polyarthritis, tenosynovitis, skin lesions, usually a small macule or papule on the distal extremities. Lyme disease caused by spirochetes, Borrelia burgdorferi, and they are transmitted by ticks. Diagnosis: Lyme disease is diagnosed clinically. The earliest manifestation of Lyme disease is reddish rash, erythema migrans, flu-like symptoms. Then in subsequent weeks, neurological manifestations: Bell's palsy and meningitis. Cardiac: AV block, myopericarditis. Arthritis can develop with knees being the most commonly affected. ELISA test for antibodies to Borrelia. Treatment: oral doxycycline 100 mg per 12 hours or amoxicillin if less than 80 years or pregnant for arthritis and skin manifestations. Late diagnosed Lyme is treated with intravenous ceftriaxone. Mycobacterium tuberculosis, spine involvement, Pott's disease, back pain, kyphosis, and cord compression. Peripheral joints, monoarthritis, typically involving hip, knee, or ankle. Viral arthritis, common viruses associated with arthropathy include parvovirus, rubella, HIV, hepatitis B and C. Clinical picture: flu-like symptoms, skin rash, acute polyarthropathy. Viral arthritis is usually self-limiting. Osteomalacia. Osteomalacia is a softening of bones due to defective bone mineralization, secondary to inadequate amounts of phosphorus and calcium. The most common cause is vitamin D deficiency. In children, it's known as rickets. Because of this, this term osteomalacia is often restricted to the adult form of the disease. Osteomalacia is not the same as osteoporosis. Osteomalacia results from defect in bone building process, while osteoporosis develops due to weakening of previously constructed bone. Causes: the most common cause of the disease is deficiency in vitamin D, which is normally obtained from diet or sunlight exposure. Dietary deficiency, inadequate sunlight exposure, malabsorption syndrome, malnutrition during pregnancy. Chronic metabolic acidosis, chronic renal failure, renal tubular acidosis. Abnormal vitamin D metabolism, such as lack of hydroxylation by kidney due to renal diseases as chronic renal failure. Long-term anticonvulsants, phenytoin, may cause hepatic enzyme induction and increases vitamin D metabolism. Vitamin D dependent rickets type 1, VDDR type 1, inherited defect in hydroxylase enzyme. End organ resistance to vitamin D dependent rickets type 2, VDDR type 2, autosomal recessive disorder of vitamin D receptors, hypophosphatemia with normal vitamin D, familial hypophosphatemic rickets, renal Fanconi syndrome, phosphaturia, aminoaciduria, and glycosuria. Clinical picture: skeletal discomfort, bone and muscle pain, proximal myopathy with waddling gait. Pathological fractures may occur. Manifestations of hypocalcemia such as tetany. It differs from renal osteodystrophy, where the latter shows hyperphosphatemia. Investigations: laboratory biochemical findings. The major factor is low vitamin D concentration in blood serum. The serum calcium is low or low normal due to secondary hyperparathyroidism. Serum phosphate is low except in cases of renal osteodystrophy. Serum alkaline phosphatase is high. Imaging: radiological findings, defective mineralization with pseudofractures, loser's zone, translucent band of bone material of decreased density may form alongside the surface of the bone. This gives the appearance of false fracture. Typical sites of involvement are scapula, ribs, pubic rami, proximal ends of the femur and ulna. Treatment: diet, adequate dietary calcium and vitamin D intake, adequate sun exposure, ultraviolet light, calcium and vitamin D supplements. Treatment of the cause: comparison of bone pathology. We have conditions: osteoporosis, osteomalacia, osteitis fibrosa cystica, and Paget's disease of the bone. Osteoporosis: unaffected calcium, unaffected phosphate, variable alkaline phosphatase, unaffected parathyroid hormone, decreased bone mass. Osteomalacia: decreased calcium, phosphate with variable alkaline phosphatase, elevated parathyroid hormone, Comment: soft bones. Osteitis, fibrosa cystica, elevated calcium, decreased phosphate, elevated alkaline phosphatase, and elevated parathyroid hormone, brown tumors. Paget's disease of the bone, unaffected calcium and phosphate, unaffected parathyroid hormone, variable alkaline phosphatase depending on the stage of the disease, abnormal bone architecture. Familiar Mediterranean fever or FMF, intermittent febrile disorder with inflammatory serositis, arthritis, and rash. FMF, hereditary inflammatory disorder, autoinflammatory disease caused by mutations in the genes MEFV, localized in chromosome 16. Eastern Mediterranean persons, especially Arabs, Turks, Greeks, Armenians, and Sephardic Jews, are most frequently affected. Clinical picture: more than 80% of all patients have their first attack before the age of 20 years. Initial attack is very rare after the age of 40. Most attacks involve fever. The attacks last from 6 hours to 3 days. Arthritis may last for several weeks. Disease-free intervals may last days or months. There are 7 types of attacks. Abdominal attacks affecting the whole abdomen with signs of peritonitis and acute abdominal pain like appendicitis. It occurs in 95% of all patients, leading to unnecessary laparotomy. Number 2, joint attacks, mainly occurring in large joints, especially in legs. Usually only one joint is affected, 75%. Chest attacks include pleurisy, 40%, and pericarditis, rare. Scrotal attacks due to inflammation of the tunica vaginalis, occurring up to 5% and may be mistaken for acute scrotum, testicular torsion. Myalgia, erysipelas like rash. Fever without any other symptoms listed above. It occurs in 25% of the cases. Complications: amyloidosis with renal failure. Amyloid protein is produced in large amounts during attacks and at a low rate between them. It accumulates mainly in the kidney as well as heart and GIT. Investigations: diagnosis is clinically made on the basis of a history of typical attacks. No specific test is available to detect FMF. Genetic test to detect mutations in the MEFV gene. Markers of inflammation: sterile exudative peritoneal or pleural fluid, leukocytosis, elevated ESR and CRP. Monitoring renal function is important, especially in patients with long history of attacks. Differential diagnosis: pyrexia of unknown origin, acute appendicitis, rheumatic fever, septic arthritis, and systemic juvenile arthritis. Treatment: symptomatic relief is the goal of therapy by NSAIDs. Colchicine as prophylaxis, 1 to 2 mg per day. It reduces the frequency of attacks, protects against amyloidosis, and stabilizes proteinuria. If the symptoms are not controlled by colchicine, then alpha-interferon infliximab or anakinra may be recommended. And finally, corticosteroids are ineffective, and this concludes the rheumatology.